We are, I think the best way of describing this is a think tank for disabled children. And we work with both the Department of Education and the Department of Health to advise them around policy for disabled children. And we then try and translate civil servant speak and government policy for those who actually have to implement it on the ground. Because as you know, civil servants don't always get out enough, and they don't always understand what their fantastic ideas will actually mean on the ground. What I've been mostly asked to talk about this morning is the Health Outcomes Forum. Our director, Christine Lanahan, was co-chair of the Children and Young People's Health Outcomes Forum. And it came about, as you will hopefully know, we had a health and social care bill. And during the passage of the Health and Social Care Bill, there was a listening exercise. The listening exercise was essentially for adults, because essentially in this country, the health service is about adults. And it tends to treat children as though they are small adults who need less medication and smaller beds. We kept pointing this out to the Department of Health, and finally they did the equivalent of the listening exercise for children and young people, which was the Children and Young People's Health Outcomes Forum. No? So it's just my presentation. That came together at great speed, very close to the end of the. Yay! That's me. And I'll say something about that in a minute. Very close to the end of the passage of the Health and Social Care Bill. I'm just going to tell you about this quote, and I'm going to talk a little bit about this report at the end of my presentation. But I think for us it really encapsulates why we think it's so important that health services for children are improved and children's experience of health are improved. Disabled children are disproportionate customers of health, and their experience tends to be poor. And this is what they want. They want it to be about them and not about them. But anyway, back to the Health Outcomes Forum. So, in January of this year, the then Secretary of State, I should say, set up the Children and Young People's Health Outcomes Forum, and he asked them to focus on 3 things. So the work of the forum was really about making sure that the new systems and structures could be made to work better for children and young people. The membership of the forum was quite wide and diverse, and it was based on individuals' expertise. So it was the usual suspects, but in a slightly different way than normal. It wasn't simply chief executives or heads of royal colleges. It was people who had a real passion and commitment. So sometimes it might not be the president, it might be the vice president, because actually that was the person who had the best knowledge. Those are so that's kind of the sort of people who were on the forum. And these were the principles that they operated to. So really that you have to look at how the health service delivers. You have to see the health service from the perspective of the child and family. Health services tend to be organised for the convenience of clinicians and those who deliver them. So they're organised around buildings, and they don't take account of the fact that actually a child is a whole child. Some of the parents that we work with can have upwards of 20 appointments a month in different places, driving around, especially for families on low incomes. You know, that kind of travel is a significant expense. Okay, so there we have the then Secretary of State. And this was kind of more of the sort of policy background, really, to the importance of the Children and People's Health Outcomes Forum. So, some of you may remember, under the last government, Sir Ian Kennedy was primed to produce kind of the same sort of exercise, really. And he did a fabulous report that came out, unfortunately, just as the general election happened. So you know what that means. That means that it goes on a shelf and nothing much happens. But this is what he said. He said that children had poor outcomes and low priorities, that GPs had little training, that there was a lack of coordination, that there was a wide variation in care. And this is why it's important, because it's not just about poor experience, it's about what the impact that poor experience then has in terms of children's health outcomes. Now, if you look at 1986, we're not doing so badly. We're partly not doing so badly because for some reason we're not measuring Finland and Norway in 1986. you see. But you can see it's kind of comfortably towards the top half of the pack there in terms of our children and young people's health outcomes stories. Comes to 2007, and believe me, it hasn't changed for 2012. Where are we? We have the highest child mortality rates in out of those countries listed there. So I don't really think that's very defensible. So that's why the Children and Young People's Health Outcomes Forum and the recommendations that they produce are important. So in terms of the kind of reasons why those death rates are so high, we, if you look at first access services, so asthma, meningococcal disease and pneumonia, our death rates are higher in the UK than these other European countries. Survival rates for childhood cancer are lower, and diabetic control markers are significantly worse. We've got avoidable deaths and potentially avoidable deaths. We've got half of children being presented at GP surgery with meningococcal disease being sent home. And we've got 75% of admissions of children with asthma that could have been prevented with better primary care. So you're not just talking about poor outcomes, you're also talking about poor experience, because you're then looking at parents who are presenting with their concerns, which a bit like, you know, the sort of school experience we were hearing earlier, where parents aren't being listened to and not being taken. Something that we hear a lot from parents of disabled children is that they're not always valued as the experts in their child's condition. And often, some of the parents that we work with, their child's needs are so complex, their disability is so particular, that actually they are the one who holds all of the expertise. Because, yes, that specialist will know a lot about that bit of their child, and that specialist will know about that. And yes, the paediatrician will hold the ring, but actually they hold all of that knowledge, and they are the only one at every single appointment that their child attends. Okay, where are we? So, yes. So there's six-fold variation in attendance by GP practice. So some GPs are sending 6 times more children to A&E than other GP practices. And in terms of public health, we've got rising obesity and we've got rising rates of sexually transmitted disease. So you can see it's not looking great for children's health in the UK at the moment. So that's why the Child Health Outcomes Forum needed to happen. And this was kind of how they framed the challenge for themselves. I'm not quite sure why the Rubik's Cube, but they were very proud of the Rubik's Cube. And I don't remember, because I never had a Rubik's Cube. I used to borrow other people's and not do them. But I think it's got more squares than it's supposed to have. But I'm assuming that that's some kind of metaphor for the additional complexity of the health service in this country. So they looked at key themes: health promotion and illness prevention. So that's kind of a public health one. Acute illness, long-term conditions, disability and palliative care, which is obviously the one closest to our hearts at the Council for Disabled Children, and mental health. And they looked at cross-cutting issues, so these ones along the bottom, and they were very keen on it being a life cycle approach. So the challenge, I mean, hopefully I've kind of outlined to you a bit the scale of the challenge in terms of where we are and where we need to be. I think the other scale of the challenge really is just the complexity of the health service, the number of different bodies involved. I mean, for instance, this morning I've come from a meeting at the Royal College of GPs, which was a joint meeting with the Royal College of GPs and the Royal College of Paediatrics and Child Health. So you've got two sort of, already just there, you've got two bodies who've got to agree on a strategy for improving child health, and that's just within a small part of the clinicians. That doesn't take into account the other allied health professionals who will all want to have a say about how it should happen. So in terms of moving things forward for health, there's a lot of vested interest, very committed, very passionate people who want to do their best for children, but a lot of vested interest that you have got to take with you if you are going to create and manage change. So, I kind of think I've done this slightly, but yes, so the key principle was life course approach, and that would create real improvement. So this kind of slide just really demonstrates why life course approach is important, because of the kind of added factors that kind of build one on top of another during someone's life. So this is a sort of cancer example, but it would work for a number of different conditions. So you can't look at a bit because all of the bits connect to each other, just like, you know, we as people are holistic. So, obviously in terms of having a Children's Health Outcomes Forum, so I'm just going to have a sip of water. It was absolutely critical, because you may have noticed that on the actual forum itself, there weren't any children and young people. So it was absolutely critical that they really did get the children's voice in there. So NCB was commissioned to enable that to happen. So there was a survey of 350 young people. There was a literature review. Young people are always telling us that they get surveyed to death and then nothing ever happens. So we were very keen that we made sure that we didn't just survey them again, but we made sure that we also presented the data from all of the other surveys that have already happened, so that it all went in together. And there were a number of face-to-face events for children and young people as well. And this is what they said they wanted. And I won't read them all out because you can all read them. But better access to child-friendly information, care to be in environments which are appropriate to their age and needs. And that tends to be particularly important for teenagers. And especially at the point of transition, you know, you're either in a, you know, paediatrics where there isn't a PlayStation and there are kind of toddler toys, or you're on an adult ward. Let me see anything else that's particularly important to mention. And I think it's interesting that children and young people themselves recognise the importance of family resilience. It's something that parents say to us an awful lot, but actually children are very clearly there, identifying that for them to be healthy and well, they need their carers to be healthy and well as well. We didn't only listen to children and young people. When I say we, it wasn't really we. I kind of use that language because I feel quite committed and close to the forum. The forum was independent. We input to it in the way that lots of other people do, so I apologise for my smarties. So the forum didn't only listen to young people. The call went out very widely across all key stakeholder groups to get people's input. And I'm going to rush through these because otherwise you'll miss coffee and you'll never forgive me. And these are the kind of things that came from the submissions. So very much chiming in with what the children and young people have said. But integration really coming across as key, and also transition. So that was a problem that people identified that we already knew. And the forum was really clear when it started that we knew, or that a lot was known about the issues and the problems. And if the forum was going to make a difference, then what it really needed to do was identify the solutions and suggest ways forward. And that was very much the focus of what was asked of those people who made submissions. So one of the things that is really clear within the health service is the importance of indicators and the way that they drive spending within health. So at the moment there are quite a lot of indicators, but there are very few indicators which actually indicate anything about children and young people. And that probably is quite a lot of the reason why children and young people don't tend to be a priority. So there's the NHS outcomes framework and the 5 domains. So preventing people from dying prematurely, enhancing quality of life for people with long-term conditions, helping people to recover from physical health, ensuring that people have a positive experience of care, and treating and caring for people in a safe environment. So that's the kind of, making sure that they don't get over-medicated and that accidents don't happen in hospital. So those are your 5 domains. Now, there is one, you can see one indicator for children against each of those. But if you were to look at the adult ones, if you were to look at the adult ones, then you might have 20. And what we found within NCB when we were doing our submission to the outcomes is that if you looked at the indicators, there were lots that actually could be applied to children and young people, but just weren't. So that was one of our recommendations to the forum, is where you can extend an indicator to give you data about children and young people, then do that. Because why aren't you measuring children and young people's data? That kind of seems to indicate the kind of priority that they're giving. I can't public health outcomes framework. And I will, if anybody wants these, I will make sure that Jay gets the slides, and apologies for you not having them in your pack. So, that was the kind of the system that they were looking at. They had all of that information coming in. So these were the emerging themes. Time for presentation at NHS setting to definitive diagnosis. Now, that's really important for two reasons. It's important in terms of, for children and people generally, preventing death from avoidable diseases because diagnosis haven't happened. But for children with disabilities, it's really critical because you do not get a package of care, you do not often, it's very difficult to get a package of care that meets the child's needs until you've got a diagnosis. I mean, some children never get a diagnosis, but that's a whole other issue. So as I said, extension of indicators focused on a limited age group within children and young people to the whole children and young people population. Medication errors that reach the patient. Something like 10% of drugs are actually tested on children and young people. That might sound like quite a good thing in that, you know, don't like to test on animals. But actually what that means is that the vast majority of children are being medicated with things that have never actually been tested on them. So we don't really know exactly. We know through custom and practice what's the right dose, but it is custom and practice. And it's kind of, you know, like an algorithm, a kind of cut-down algorithm, or you weigh this, so it's probably going to be all right. But actually, long-term tests haven't been done to check that that's the fact. For the public health operating framework, the themes are related to extension of current indicators to strengthen and forget children and people. So going back to what I was saying before, so extension of the suicide measure, extension to measurement of weight to cover the adolescent age group, and really important one, I think, and especially bearing in mind the previous presentation, education, attainment and progress to be used as a measure of effectiveness. For the adult population, employment is used. We work with a lot of children and young people, or work with agencies who work with them, where they're missing school because of ill health or disability. And we need the health service and the education service to work together so that actually that's not the reason why a child's not in school. So I've kind of said a little bit about the difficulty of change within the health system because it's so complex. And this kind of helps. I'm not going to go through it all before you get worried, but this explains something about the complexity of the health system and all of the different parts that interact. And hang on, is that no? It's not even finished yet. I get worried in case I go on to the next slide before I'm ready. There you go. So those are all the different bits that kind of work independently, have to work together, that we need to impact on across the piece in order to make change happen. And those are the levers that we can use. So we're really happy, for instance, that Christine Leonard, our director, has now been invited onto Health Watch England because we think in terms of patient voice, that will make a critical difference in terms of getting children and people's voice into Health Watch. But we need to do the same thing with all of these other things. So, in terms of the system, 3 lenses were applied to the system. Looking at the journey through the system from the child's perspective, looking at those cross-cutting things, and looking at the organisations of the institutions. And 3, because of what I said earlier on about the passage of the bill and the speed at which all this happened, and that this was very, very last minute, kind of Cinderella territory, running home after the coach had turned back into a pumpkin. These 3 recommendations were actually put to the Secretary of State as was before the report was published. So I think only 40% of GPs have any training in paediatrics, and I think that training is something like 3 months. Young people represent 25% of their caseload. So I'm going to dash through these because I've got a warning. So those are the other recommendations. You can read the report anyway. What I will make sure is that, that you've got a link to the report. And these are sort of some of the examples of the recommendation. The big issues about data in the health service and us not really knowing what children and young people's needs are because we're not collecting adequate data. I've mentioned a bit about medicines, the need to improve safety there. The NHS mandate needs to really reflect the objectives for children and young people. We want the child health records to be electronicized, is that a word? I think I've made that up. Also, what we want is for there to be a unique identifying number. We're suggesting that the pupil number gets used across education and healthcare, because that's the only way you could actually do what we want, which is for pupil absence due to ill health to be measured. Okay, so blah, 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 blah. Are they going to get a chance to ask any questions?
If you finish.
Okay, right. So I'm just kind of wondering what I need to tell you what. If I just speed through this, and if you've got questions where you want, more information, you can ask them. So basically, the report was submitted to the government. Government changed. Not entirely, but the Secretary of State changed. Obviously, quite a big thing. Slight panic in case the new Secretary of State wasn't on board. New Secretary of State appears to be on board, and they will be responding. But whereas they were supposed to respond at the end of the summer, obviously it's the government end of the summer, which is probably late winter. We are currently drafting our response to the NHS draft mandate. And I just want to tell, I have to show you this because it is so public. We've got a sound, by the way. Good. It wouldn't come up yet. So this is, it will only be really quick, but this is the best summary that I have of the report that we did from the, it was a piece of work that we did with disabled children and young people, asking them about their experience of health services and how they wanted that to be improved. On our website that you might find interesting, especially if you were a clinician, and you can ask them about those. And yes, and I think that the biggest message today is there is a lot of change, but there's a lot of appetite for change, and quite a lot of it doesn't necessarily require a massive investment. It's about training, it's about attitudes, and it's about putting children and young people at the heart of their healthcare. Thank you very much.
Okay, well, I think two very interesting inputs particularly around education and also health disability and the services that ought to be provided for those. And I think, certainly from my experience, we all start open from a basic commitment, really, that particularly for children and young people, because they're at the beginning of their lives, we can and ought to address the barriers to wellbeing and development, including education, that we ought to be able to organise our services in ways that integrate those services, so they're dealing with the whole child and the family, and are very child-centred, as Amanda said. But actually, we've got a tradition in this country that the default position very often is that our services revert to type, and they stay in silos, and that it's very difficult to constantly drive the integration that's necessary. And certainly when I was Minister, schools complain about local authorities, complain about schools and health. Health were often not at the table, and it was very, very difficult. I think progress was made, and I think you're right, there's attitude. That there is appetite, but cultural change, I think, is still needed. Now, we've got people here from all of those sectors. So let's hear about your experiences and your views on this. I think a very important issue that's at the core of actually really serving vulnerable children well. So who'd like to start? Yes, gentleman at the back. I'm going to take a couple of 2 or 3 questions and then let Jan and a comment rather than do it one for one. So please.
It's a comment really. I'm Roland Gooding. I'm head of Valence School in Kent, which is a day residential school for children with physical and medical needs. Just wanted to say that what I've just heard about health, it's not all like that. There is some very good practice around, some very good experiences. In my own school, we have 5 consultants who visit, so the children can be seen with their parents or on their own or with staff they choose to be with them. And I think that there is, wrapped around multidisciplinary care, much of what the wider experience which the last speaker spoke about. And my question is any work being done to identify good practice rather than just asking people their experiences?
Thank you very much. Another? Who else would like to come in? Yes, lady again now. Thank you.
Hello, I've got a question for Jan Tallis. You commented on parent-condoned absenteeism. Do you have a view on school-condoned absenteeism?
Sorry, on what? I couldn't catch that.
School
condoned. Yeah.
condoned absenteeism. I'm thinking of coding in registers, and where children have been, or youngsters and families have been encouraged to educate at home as an option rather than being excluded. Children's Commissioner wrote a report in the past year or so on children's attendance at school where some of these things were highlighted, and I haven't heard much since then, so I just wondered if you knew what's going on around that and a general view. Thank you.
Thanks. Sorry, did you say who you are and where you're from?
Yes, I'm Sally Lightfoot from Family and Parenting Support in Warwickshire.
Thank you, Sally. Okay, let's take one more and then we'll just have some comments on this. Yes, there in the middle. Can we get a microphone? Thank you.
Andy Byford from Durham University. Just want to ask speakers, but perhaps also other members of the audience, whether there are any sort of frameworks that make collaborative expertise in child issues an explicit issue, so the problem of collaboration between different experts, whether there are very specific frameworks that deal with issues of collaboration between experts.
Do you mean frameworks that kind of policies, procedures on the ground that require people to talk to each other, that kind of...
Yes.
Around individual children as opposed to policy?
Yes, and whether it's sort of fostering a particular culture or whether it's kind of schematic in a procedural way.
Thanks. I mean, we did have multi-agency teams emerging in many of their areas, including centred on many schools, actually, and I think it's unclear how far those have been allowed to be sustained in recent years. But let's take those 3. Now, you don't both need to speak on everything, because I want to take some more questions, but let me ask you, Jan, to pick up what you'd like to comment on and then pass to Amanda.
I'm not going to attempt to talk about the first one, I know nothing about it. But school condoned absenteeism. Yeah, it's a really interesting report by the Children's Commission last year. She's doing another one this year. She's gone back and looked again. And in fact, School and Sport have given her some evidence around that. It's been interviewed by it. It is shocking that rather than deal with the issue that children are just asked to go home and it's not recorded and they're not supported at home, they're not given stuff to be doing. I mean, formal exclusion is bad enough, but at least there's a requirement there from the schools to actually put in place some systems. Informal absence exclusion is really, it is right, I'm afraid, and the Children's Commissioner, as I say, is looking at it again now. She's taken evidence at the moment now. So if anybody has got anything that they want to submit, I'm sure she'd be really keen to hear about it. On the collaborative frameworks, I think that they were being strongly encouraged, and they're now voluntary. I do sit on a children's trust board where the police come, social services come, youth services and family support services and schools and the local FE colleges, but they're not universal. The other interesting collaboration is around, and I can't remember what it stands for, the MARACs, which are multi-agencies teams that particularly focus around domestic violence. But they often are there looking at what's going on for the children as well, and so they're quite important places. Again, often chaired by the police, but with heavy involvement from social services and the voluntary sector, like victim support and domestic violence agencies that are advocating for the victims.
Okay, thank you.
I'll do the last one first, just because then it will follow on. In terms of disabled children and young people, there's quite a lot of work going on at the moment around integration. We are in the pre-legislative scrutiny phase of the new Children and Families Bill, which is hoping to bring in a single assessment and a single plan for children and young people, and a duty to cooperate. And at the moment, I think there are 20 local authorities who are pathfinders for the single assessment and the single plan, and that is actually, I mean, that kind of whole integration cooperation thing is an entrenched and intractable problem that parents have complained about and local authorities have struggled to deliver on because it is difficult, not because of lack of desire or commitment for many years. So it's not surprising that the pathfinders are struggling to identify a solution, but that work is going on. There is also, as a result of the Health and Social Care Bill, we've now got the Health and Wellbeing Bill, and they should have an overview of children's health and wellbeing across the piece. In terms of the first question, I mean, I guess what I'd really say is we all know that change, to some extent, you have to play the change game. So if you want things to change positively, yes, maybe it's not very nice to all those people who are doing a fabulous job and are incredibly committed, but of course you have to highlight the things that aren't going well. And no, that doesn't mean that isn't some excellent practice out there. The meeting that I was at earlier on, Sheila Shriverman, who's a clinical director for Children's Health at the Department of Health, was saying that the government's response to the Children and People's Health Outcomes report is one of the things that they're currently discussing is putting in best practice examples in there so that people can see that it can work. But I suppose the only thing I would say to counter all of that is actually, you know, I showed you a graph. Yes, there's excellent practice, but we're not doing well enough.
Thank you. Just for information, certainly on the draft children bill that we're expecting to be republished sometime in the new year, and hopefully it may change, but certainly in the draft, the single assessment for social care, health and education and the planning that comes from that will only apply to children with a special educational need at the moment. So for disabled children without a special educational need, they will not fall within the remit of the bill. Well, you may think that, but until the ministers publish the bill, we don't know if they've taken those points on board. Right, I've got time for another couple of questions if somebody would like to ask one. No word on your coffee. We've got two here. We'll take those two, please, and then we'll break the coffee. We'll take that man there because he's close to the microphone, and then we'll come to you.
Thank you, Michael Bamford, on the Health and Wellbeing Board in Suffolk. One of the key levers in sort of breaking the cycle of deprivation and poor attainment is the prevention of unplanned and young pregnancy. My question is really relating to whether there's an approaching a rational is there a rational approach to offering a sense of advice within schools over the piece and in the face of some rather irrational opposition? And what are the outcome measures? Have they been determined for successful intervention in this area? Thank you.
Thanks, Michael. Can we bring the microphone down quickly down here to this gentleman at the front? Thank you very much.
Yes, good morning. Alan Ribeiro, I'm the Councillor for Solihull MBC, Chair of Education and Young People Scrutiny Board. Solihull is pathfinder in the pilot programme. I think it's a case of, sorry, can you hear that? It's very much a case of we've had evidence of the health situation and the input for children. With the bill in front of us, it's coming from the Department of Education. In a statutory sense, we're not getting the same from health. Do you think that's a barrier? Because whilst the health and wellbeing boards are there, I think CCG commissioning really hasn't got a statutory requirement as yet, and I think that's an issue to consider.
Yeah, we couldn't get school representation on the Health and Wellbeing Board during the passage of the bill, so there is a gap there, I think. Jan?
Yeah, I can't answer the second one, so I'll leave that to go over there. On the first one, teenage pregnancy in schools, yes, not a minefield. It's really effective when it happens, and the numbers did start to go down in teenage pregnancy, yeah, quite dramatically. I don't know what's currently happening, I'm afraid. I don't know if it's going on in PSHE or not, but clearly good information just helps people make the right choices, and the more of it we get, the better it's going to be.
The government has been reviewing PSHE for some time, and we're still waiting for the outcome of that review, Michael, on whether there will be any shift in terms of sex and relationship education and the inclusion within that of specific advice around avoiding conception. I hope that review will be published fairly soon.
I know exactly what you mean. When talking to the Pathfinders, quite a number of them have really struggled to get health buy-in. I think one of the issues is what I was referring to earlier on, which is the complexity of the structures within health. So when I was at a meeting with clinicians and the Department of Health and Department for Education were there, what the clinicians were saying is the local authorities are talking to health managers, they're not talking to clinicians. And obviously, within the local authority, you have got a disabled children's lead. You've got, a really clearly identifiable person who can take accountability and responsibility for driving that through. And it's just, there is a network of relationships that have to be built up within health to do the same thing. So obviously it's more complex and it takes more time. And I think that's one of the areas where we really need to help local areas to learn from those where it's happened. I mean, I think very often it is about building relationships. We were talking earlier on about co-location, maybe GP surgeries and children's centres being co-located so that you get sort of more of that cross-fertilisation. I mean, hopefully, I think the difficulty, of course, at the moment is the health service going through this massive change, so all the health service managers are, are going or transmogrifying. So hopefully, once it's settled down, but we're just sort of pouring change on top of change at the moment, and obviously making it difficult for people. That probably doesn't really answer your question, but we're aware of